Bismillah ar-Rahman ar-Rahim. Good evening. It gives me a great pleasure to be here this evening in this great meeting. My topic today is about how do we manage glaucoma after vitreoretinal surgeries. The surgical management of retinal disorders, including scleral buckling procedures, pars plana vitrectomy, intravitreal injections of gas or silicone oil, can lead to a short-term elevation in the IOP and ultimately to a long-term glaucomatous damage if not treated in timely manner. Moreover, the primary open-angle glaucoma experience retinal detachment at a higher rate than normal eye. Also, the prevalence of myopia as a common risk factor in both disorders. I will focus today on management of glaucoma after pars plana vitrectomy. Few studies report that the incidence of glaucoma after uncomplicated pars plana vitrectomy is about 10 to 20%. There are two risk factors increase this incidence: pseudophakia and silicone injection. The mechanism postulated that the oxygen from the retina diffuses to the anterior chamber, which induces oxidative stress to the angle structure. I want to review this clinical case with you. Patient, 42 years old, bilateral congenital cataract emulsification since childhood. Currently, single right eye retinal detachment repair with vitrectomy and silicone intravitreal injection since 4 months with IOL. Sent to me with high IOP, more than 35 mm mercury with max medication and visual acuity 0.15. I thought it's good option for him to do one session cyclodestructive procedures micropulse, and I achieve a good result. The next day IOP between 8 to 10 with 3 drugs. After 3 months, the silicone oil has been removed and visual acuity improved to 0.4, IOP about 15 with good optic nerve. But after 2 months, he come back to me with elevating in IOP 36 with max medication. So I decided to put Ahmad valve as a good surgical procedures for him. Next day, everything is good, and the IOP between 7 to 8 and visual acuity 0.4. But unfortunately, after 1 month, he came back to me with decreasing in the visual acuity 0.05 and IOP 6 and OCT showing us cystoid macular edema. I thought that the reason is from the hypotony, so I minimized the lumina tube of Ahmad valve in order to increase the IOP. IOP increasing during few days to 12, and I put my patient on steroid, systemical and tubical and non-steroid eye drop ocular, but without any improvement. The retinal surgeons decided to inject him by anti-VEGF Avastin, also without any result. But when we inject him by Ozodrex dexamethasone intravitreal implant, we achieve very good result and improving in the visual acuity, so we suggested that there is inflammatory mechanism. As you see, the glaucoma management after pars plana vitrectomy need close post-operative follow-up, long-term follow-up, meticulous surgical technique, and careful with using steroid. The pathogenesis of the glaucoma after vitrectomy is unknown, but there is early onset by silicone oil overfill or silicone migration, steroid-induced fibrosis reaction, and papillary plug with 2 mechanisms, angle closure and open closure and open angle. And late onset by trabecular damage, neovascular glaucoma, silicone oil emulsification, and peripheral anterior synechia. When there is elevation in the IOP after pars plana vitrectomy, we generally used aqueous suppressant as a medical treatment with caution or attention to the causative element like patent iridectomy, overfilling silicone oil, iris neovascularization, and surgery indicated when the medical therapy inadequately control the IOP. You know that the surgical management carry a lot of difficulties, and when the papillary plaque is involved in the mechanism of glaucoma, the laser therapy iridectomy is indicated. Cyclodisruptive procedures, previously micropulse is a good option for us to reduce only also the IOP. Maybe we need more than one session. Conjunctiva is in a poor condition after pars plana vitrectomy. So glaucoma drainage devices is a good and important option, especially when there are high rate of failure from the standard filtering surgery. And when there is silicone oil in the eye, remains in the eye, the tube should be positioned on the inferior quadrant of the eye. Sometimes pars plana tube were placed and pars plana vitrectomy was performed either prior to or concurrent to the tube placement. At the end, post-vitrectomy glaucoma is not uncommon problem with many variables. Prompt diagnosis and treatment, closely monitored post-operatively, can prevent further ocular damage and improve patient outcomes. Don't imagine that you will reach to all you want or you need to know from this lecture. This lecture is an introductory lecture. Thank you for having me. With all love from Damascus.
Thank you, Dr. Val.
Thank you.